propose that the way we're going to control costs is in three ways, if you read the proposals that are out there for this kind of plan. One is computerization. The CBO says that generally the adoption of health IT, information technology, is not sufficient to produce substantial savings. They say that disease management will not generally cut costs, and it might in fact cost more. And comparative effectiveness research, while useful for understanding what are the best treatments, is unlikely, and we think that they think that the effect on the budget will be limited. These will not, in fact, lead to serious cost savings. So what's an alternative? The alternative that I have supported for many, many years now is a public program in which everybody's automatically enrolled. It's like Medicare for those of us over 65, but it would be available to everybody. Everybody would automatically be enrolled. There are full benefits, free choice, no networks, free choice of physicians, public funding, and costs can be contained. This is the crucial point here. Costs would be contained under this kind of plan through planning of capital investments, through budgeting, and through an emphasis that could be actually carried out for primary care, which is much more cost effective than high specialty care. How would it be financed? We don't have a national study, but we have studies from many states. This is from a study done by the Lewin Group of the California single payer proposal, which their legislature passed twice. Basically, it says that the federal and state governments would continue their share, which is about 45 to 48% of total expenditures today. And it could be funded by an 8% employer tax and a 4% employee tax at the moment. And that would be the total expenditures. That is, this is a plan with no copays and no deductibles. The total expenditures that families would have would be 4% of their income. Employers today who provide insurance typically spend 11% of payroll on insurance. This model has 8%. How does it do it? Well, one way is it gets rid of the billing costs that we now experience through this complicated multi-payer system that we have. This is where the dollar goes that goes through the insurance companies. And if you look at it carefully, you'll see there's insurance company profit and overhead here. There's insurance company billing, processing of the bills. There's hospitals that have to have billing departments. There's doctors, as Dr. Balazet said, that doctors have to have billing clerks who deal with insurance. That adds up to about, according to this estimate, 28% of all our spending. Medicare's cost is 3%. The rest of this is actual medical care. So this kind of a model would save those costs. If you actually cost it out, this is, again, from the Lewin study of California. It costs more to cover everybody than we're now spending. This is their estimate, extrapolated from California to the nation, is about $240 billion. Part of that to cover the uninsured, part of that to cover the underinsured, and part of that to get rid of cost share of copays and deductibles, which I believe keeps people from getting care they need. Other countries don't use copays, and we shouldn't either. But on the other hand, there are significant savings from reducing all those billing costs and from emphasizing primary care and from the efficiencies of doing bulk purchasing of drugs and other things. The Lewin study says there'd be a net saving. What would we use that for? We'd use it to retrain the people who now push paper and who could be retrained, or other people could replace them to provide more medical care, which we will need in a comprehensive system. So what's the bottom line? It's that the private-public mandate model will make the world's most expensive healthcare system even costlier. It will not improve insurance coverage for the average person because it doesn't affect them. It will not make affordable insurance available, and it won't contain the continuing growth in costs. In other words, it won't work. The bottom line is it will not work. Only a national health insurance plan can cover everyone for comprehensive services, cost no more than we're now spending, and provide a mechanism for containing costs going into the future. What happens if we don't succeed this year in getting a really good plan? Here's a projection from the family physicians. Here's today, the median income. The median income today is about $50,000 according to the Census Bureau. The typical insurance policy, family insurance policy bought by an employer, is about $12,500. If you track the rate of growth of incomes, which is about 3%. You track the rate of growth of insurance costs, which is somewhere between 8 and 10%. At about 2025, insurance premiums will take our total income. And I guess my projection is that sometime between now and 2025, we will in fact get real healthcare reform. The sooner the better. Thank you.
Thank you very much, Dr. Leonard Rodberg. First of all, how many congressional staffers are here? Can you please say which offices you're from and who you are?
Virginia White, Silver.
Okay.
Rebecca Schwall, Philadelphia.
Okay. Which one? Okay. Any more?
Congressman Capiano.
Aha, the member of Congress on Energy and Commerce Committee. Is that correct?
I'm actually an intern.
Oh, cool. That's all good. All right. Anyone else?
We have
Eva Dominguez is in office. Sorry.
From Keith Ellison?
Yes.
Melissa from Congress.
Barney Frank. Okay. Round of applause for Barney Frank.
Christopher Dowd, Congressman Sarbanes.
Wow, okay. We have in the audience too, there's a few special guests that, is this Melody over there from National Organization of Women? Can you introduce yourself?
Hi, Melody Denafro now.
You've heard of now the largest women's advocacy organization in the country.
It's also our biggest feminist.
And then, sir, can you introduce yourself?
Nick Unger with the AFL-CIO.
So Nick's in charge of universal health care reform for AFL-CIO for the whole thing. We got Donna Smith from the movie Sicko. I'm working with the California Nurses Association. We got, is that Mark Dudzik? Can you say who you are?
Mark Dudzik with the Labor Campaign for Single Payer.
And how many labor unions does that include?
We got about 150 labor leaders in 31 states around the country that are actively working with us right now.
Cool. Is that Joe Jerzak? California Nurses Association? Is that Fredette West, who was responsible for putting minority health disparities on the map in the United States Congress? Can you raise your hand and say hello? All right, so the reason why I want to let everyone know in this room that some of the most, where's AMSA, our leader from American Medical Association? Can you introduce yourself?
My name is Liz Lydic with the American Medical Association.
And who's that over there in the corner?
I'm the National Legislative Director for AMSA, the Women's Bureau Bureau.
Fantastic. So what we have in this room are some of the single most important leaders for healthcare reform and universal healthcare in the nation. And I don't think that's any small, thing. So can we get the leadership conference regarding healthcare with round of applause? Can you introduce yourself?
Katie Robbins with Healthcare Now.
And what's Healthcare Now?
We're the National Grassroots Advocacy Campaign for Single Payer National Healthcare.